everyone. My name is Laura Bloom, and I'm going to introduce our panel discussion now. And it's my absolute pleasure to welcome Nadia Hanim Abdul Latif as our moderator for this session. We don't have enough time today to share all the accomplishments our moderator and panelists have, but I would like for Nadia to kick this off with a discussion and a self-introduction and take it from there. Thank you. Over to you, Nadia.
Thank you so much, Lara. Hi, everyone. Ni hao, selamat petang, assalamualaikum, guten tag. Hope everybody is doing well. Kia ora to all of our families in New Zealand. And we hope that the weather wherever you are is better than the weather that I'm seeing outside my window right now. But let's hope that tech upholds. We have an interesting session today. My name is Nadia Abdul Latif. I am the proud mother of Iman Raisa, who is 14 and a teen with Phelan-McDermid syndrome. I am also the regional representative of the Phelan-McDermid Syndrome Foundation for Southeast Asia, Qatar, Oman, Kuwait, India, South Korea, and the president of the Malaysian Rare Disorders Society. Today, I have with me an illustrious panel. We've got Edmund Lim, James O'Brien, Dr. Elmer Palmer, Dr. Chung Gaik Siew, and of course, Kris Pierce. Now, today we're going to be having a heart-to-heart discussion about what it means to become a rare disorders advocate. Is it the rise and fall that defines us? Is it the love or the lost? Today, we have these esteemed panelists that will be sharing their joys, their frustrations, and everything to do with advocacy in the rare disorders space. So without further ado, we're going to go first to Edmund to introduce himself, and then to pick the next victim to introduce him or herself. Over to you, Edmund.
Thanks, Nadia. Hello, everyone. Calling in from Malaysia. It's good to see everyone from around the region. This is the first time we're doing it with Global Gene, so we're really excited. I found a non-profit organization that focuses on spinal muscular atrophy. Like all parents, we sort of end up in that journey, obviously, because someone's affected. For me, it's my second son, Brandon. So he's born with spinal muscular atrophy, and that's how I ended up in the journey. We do a fair bit around healthcare, but over time, we're looking more beyond healthcare as well. So there's a lot of things lined up. And today, I think I'm really excited to hear the stories from everyone else on the panel because there's so much to learn. And I'm going to quickly pass the baton on to my good friend, James, to introduce himself. So over to you, James.
Thanks, Edmund. Hi, everyone. My name's James O'Brien. I have two wonderful children. My son, Ashley, lives with a rare and complex genetic disorder known as Prader-Willi syndrome. PWS affects multiple systems in his body at various life stages, and he will require support throughout his life. For individuals with PWS to survive and flourish, families, teachers, health professionals, and social care workers need to access expert knowledge about the syndrome. In my roles as chairman of Prader-Willi Syndrome Australia, and Vice President of the International Prader-Willi Syndrome Organization, we have united a global PWS community from over 130 countries. Collectively, we seek to seek solutions for the challenges that people face living with the syndrome, and therein enabling them to reach their best potential and achieve their goals. I now invite Emma to introduce herself.
Thank you very much, James. And it's a great pleasure and honor to be here as part of this discussion and part of this meeting. And it's so wonderful to see Global Genes having these regional meetings. It's such a great step. So I'm a pediatrician, a clinical geneticist, and a university lecturer. So in my clinical practice, I see children with rare diseases, and in my research and in my education work, I'm trying to improve the model of care. So trying to walk alongside those with rare diseases, hear where we're going wrong in the medical provision, and try and work together to get some solutions for more families, not only in our region, but internationally. And I'd like to pass on now to Dr. Chang.
I think Dr. Chang is having a little bit of a technical issue.
No worries. I couldn't see her face. Shall I pass on to Kris?
Yes, let's do that.
Lovely. Over to you, Kris.
Thanks, Emma, and thanks for joining us. So my name is Kris. I'm in Melbourne, Australia, and I'm the parent of a child with a rare genetic condition called SCN2A. And if you were on earlier, you would have heard Ursula talk about her daughter Eva and the challenges that many of our children with SCN2A face. So we set up a group here, organisation, to help support families here with the rare condition, doing a lot of advocacy, a lot of agnostic work, because in Australia the numbers of families with our gene are quite small, so we need to band together, and it's one of the things I'm actually most proud of is the way that we work collaboratively, not only with our own families but families across genes, and also our researchers like Emma. You know, this collaborative work is only going to ensure that our families get the best outcomes, and there's a lot of good things coming down the pipeline. The other thing that's been really important for us to be working on is preparing our community for clinical trials. SCN2A has not been around for a long time, but it's actually punching above its weight in terms of heading towards clinical trials, and we hope to actually have first clinical trials in the last quarter of this year, early quarter next year, and that's both for a small molecule and for an ASO. So we are galvanising our community to be ready and really advocate to get clinical trials here, because having clinical trials and access to medicines in other countries doesn't help our families, and so that's why it's really important for us to be doing that advocacy work here. So thank you for having me, and I will pass back to Nadia.
Thank you so much. Let's see, do we have Dr. Chung back on right now? Dr. Chung, are you with us? Not yet? Okay, don't worry. We will introduce her as she comes. Now, thank you so much, everyone. I'm seeing on the moderator panel a lot of love and different families here. So everyone here, if you have a loved one with rare disorders, or if you yourself is an individual living with rare disorder, hit a +1 in the chat so we know how many people are here. I see Pamela Todd. Hi, Pamela. Hi, Craig. Hi, Azhar. Oh, there's Parvati. Okay. Now, while we look at the questions that are coming in, feel free to type your question on the Q&A box. In the meantime, I'm going to kick off with the first question, and this is for you, James. So you were fortunate enough to be granted with the Churchill Fellowship to study regional, rural, and remote delivery of person and family support services. And this has been even more important now amidst the pandemic. So during your travels around the globe, what was it that stood out for you? What were the standout or the gold standard programs that you saw? And what were some of the lessons that you learned from this?
Thanks, Nadia. I indeed did consider myself fortunate to be granted a Churchill Fellowship, which funded me for travel for 6 weeks overseas for research. However, I took it upon myself to augment the scholarship with my own resources and ended up traveling for almost 5 months, meeting hundreds of people in the rare disease community, families, people with rare disease, doctors, scientists, researchers, and people involved in government. I returned to Australia with 22 recommendations for Prader-Willi syndrome Australia. And you can actually find my rather long-winded report if you Google James O'Brien and Churchill. Prader-Willi syndrome Australia has managed to implement numerous of the recommendations. However, we've been unsuccessful in securing funding in Australia for one of the most significant findings. Due to the complexity of supporting people with PWS, most individuals, sadly, die prematurely. The main reason for this shortened lifespan is a lack of knowledge, expert knowledge. So one way that I found that we can transfer the much needed knowledge is by implementing ECHOs. Now, Project ECHO is an initiative of the University of New Mexico. Each ECHO stands for Extension of Community Healthcare Outcomes. What the program seeks to do is to transfer complex knowledge from the minds of usually city-centric experts to the minds of doctors who work on the front line where the individuals are living. This demonopolization of knowledge is enabled through technology-assisted, all teach, all learn online communities of practice. The hub experts train the spoke learners in dedicated communities of practice. If you like, it's a bit like the hospital rounds in a university hospital where you're training new doctors. They receive some information, some new information, and then they discuss the identified cases and together come up with solutions. Now, whilst we haven't been successful in finding the funding in Australia, we have received funding to run these programs international out of the UK. And we're currently running 4 echoes, a Latin America Health Echo, which is being run in Spanish across South American countries, an international PWS Health Echo, training doctors across the world, a professional providers and caregivers echo. Now, the professional providers are the ones that give support to people that might be living out of home or that are trying to access the community. And we're running a leadership echo, which is fostering the development of support organisations across many countries.
Thank you so much. I think that's so inspirational. And if you think about how we are trying to reach the most marginalized, the ones that have access problems to accessibility, to availability, to affordability of resources, especially in this uncertain or certainly uncertain times, I think it's crucial for us to be able to find ways to reach those that are otherwise not in the mainstream care. The good doctor is back. So what I'm going to do is combine a 2-in-1. It is my pleasure to introduce Dr. Gaik Siew from Malaysia, but I'm going to do a 2-in-1, doctor. So I'm also going to be asking you a question so you can answer the question and introduce yourself at the same time. So doctor, previously in Malaysia, we've had no research that had been done on at least documenting the living realities of patients with spinal muscular atrophy in Malaysia, among the many other rare disorders that are also in need of definitely more research, more big data to be able to inform policy and action on ground. Now, this extends not only for the patients themselves, but also their family members and their extended caregivers. That is until living with the spinal muscular atrophy in Malaysia study was carried out. So well done to you and the team and all of the different groups that came together to do this. I'm going to be asking a question to Edmund after all, so he's going to be able to continue with this. But how did you come about to become the principal investigator for this program, and why? Now, what was the call to action for you? What were some of the key lessons that you learned while conducting the study?
Thank you for the question, and I'm so sorry for the the slip up, and I had to run to another place to get hooked on. So I'm Dr. Chung, or Gaik Siew. I'm a clinical geneticist and a pediatrician, and I'm based in a Ministry of Health. Clinical geneticist, we advocate for patient support, and as a coordinator as well to also educate the other healthcare professionals. So I think to have this research going, it was a very important thing, because this is, I think, the first step possibly to actually have a clinician and a patient support group working hand in hand in a research, meaning that we want to actually elevate the voice of patients. This is something very commonly done in the West before, but not so much in the Asian perspective or in the low middle income countries. We know that RD patient community has always actually played a critical role in the West and even in Australia in driving initiatives, isn't it, for development of such programs that address the needs of this community. So I think for us, we have a clarity of purpose, and the reason why we wanted to do this is all along our SMA community has no such opportunities to access clinical trials and also to receive all these novel therapies, unlike in other countries. And why is that so? We know that, data is very important. Mm-hmm. And in Malaysia, as a lower middle income country, or in other countries, rare disease registry is not so easy to come by, and to get burden of disease data is very difficult. So I started off with, a very basic step of just getting the estimated prevalence back way in 2018. And this was just a follow-up, to create more awareness, and also to kind of hopefully to engage the pharma industry, because as you know, they like to know data before they can even want to engage with the community or with the government. So this is what we have. So we have clarity of purpose, which is very important. And with that clarity of purpose, we want to get treatment for our community. We want to have access like every other, community in other place in the world. And that just naturally, just building in the structure. And how do you go about that? We just need to think of getting the correct people. So we have WeCare Journey supporting the logistics, working hand in hand, getting the grant from the pharma industry. And I myself, doing the clinical part, we know that to kill 2-3 birds with one stone, getting counselors, in fact, I got genetic counselor students as a repertoire in, helping out with our in-depth interviews and focus group discussion. And that is actually a very important way for them to actually engage from the very beginning in their career, to actually, know that this is something very important. To be a genetic counselor, you need to be challenges. So this is what we did. And so the counselors become the research. So that's the most important thing, actually. And when we actually, have this clarity of purpose, all align in the goals. So this is why we managed to pull this off. Yeah.
Thank you so much, Doctor. And I think really it's not only about the fact that there isn't enough data that's out there and that's why we need it. I think it really speaks to the person that you are, the person that Dr. Palmer is, and all of the researchers that are here obviously are drawn to, a higher purpose. I'm sure if you wanted to do something that was more mainstream, you'd probably be able to do so many other research studies that would probably be able to give you even more grants, right? The reality of it is the space of rare disorder is quite niche. So I have had a lot of researchers and academicians and doctors telling me, well, this is not the space you want to be if you want to make copious amount of money, unless, you belong to specific companies. But even so, I think the whole question today is, how do we bridge that gap? How do we tackle some of this divide? So with that, I want to go to Edmund, and expanding on what Dr. Chung earlier said. She was talking about the fact that there was no reliable data that was available to not only inform in policy making, but also give a little bit of an understanding to families about what's actually happening. Now, WeCare Journey has done so many different things, not just working on its own regionally and internationally, but also in the home front in trying to connect the dots, working with multi-stakeholders in the process to try and help families, especially those that have newly diagnosed children, to be able to kind of make their way and understand the complex and often scary and bewildering space of having a diagnosis with rare disorder. And Ed, being a parent of 2 children with complex medical condition, I wanted to ask you a 2-pronged question. So the first question is, what in your experience or in your observation has enabled families to remain positive and resilient despite the fact that they've gone through or received complicated medical condition diagnoses? That's number 1. Number 2, what are some of the things that perhaps WCJ has done and has worked in trying to allay some of the concerns and fears of their families?
Thanks, Nadia. So the first question, which is around staying positive and resilient. I think when we did the study with Dr. Chung, in there, if you pick up the study, it's on the website called smacare.org. So if you go in there, you see the infographics in the report as well. There's so much data which they collected, right? There's so much, because it was not only a quantity study, but it's a very extensive qualitative study. So in the qualitative study, there are a lot of quotations and a lot of sharing, which, you know, we've tried to summarize the key things in the report. And when you go through it, you would start to get an idea on possibly what are the key elements that make a difference. But one of the challenges is it works differently for every family. So I don't think every family works the same way. Having said that, I think there's still some key pillars, right, or some key elements which keep a family from either going through a journey of post-traumatic growth. I see it as that, right? It's a journey of growth, or do you sink? And we have seen both, right? We have seen both. For the ones which do grow, a couple of things I see has always worked in their lives is firstly acceptance. We're really understanding, accepting what it is. Now, accepting doesn't mean you know everything about it.
Yes.
But I think there's a level of acceptance of what this means to them as a family. And then deciding, and the second thing is, you know, the acceptance leads to a decision on what you do, right? Do you ignore it, or do you carry on your life? And when you carry on your life, I think you can't say everyone will make the same decision or should be making the same decision. Everyone needs to make a decision for the family within their own context. But I think it starts from there. Now, there are many other elements, so I don't want to take up, because that's going to take a lot of time, right, to sort of share all the things that we saw could make a difference. But that seed, I think, makes a big difference, right? That point of acceptance throws them on the path of whether they try to grow out of this or they try to avoid it and we've seen that happen, right? They sort of spiral down. And it's quite unfortunate.
And I think it's also about going through the process of grief, right? I mean, before you can accept it, you also have to kind of internalize what this means to you and your family, because there is an impact, right? It's not.
Yes.
It's not like by the time you get paper tomorrow, everything's going to be the same. In fact, things are going to change.
Yeah, and that's a good point, saying grief, right? Because when I look at then what WeCare Journey does, right, in terms of the healthcare space, there's all the physical things you can do, right? The rehabilitation, you know, the seeing all your different doctors, your swallowing tests, your, you know, respiratory tests, all these things you can do from a physical point of view. But there's another big segment that came up from the study, which is the mental health issues. And one of the big things in the mental health was exactly what you said, grief. How do you work through grief? How do you work through hopelessness? How do you work through trauma? How do you work through abuse as well? Right? How do you work through all the social stigmatization that happens? You know, and when I look at that space from what WeCare Journey is doing, I think the healthcare space is probably easier than to work on, because there are stakeholders there, there are things, there are unmet needs, they're well documented, and they're, you know, the protocols, it's just getting those protocols and figuring out how they apply in a local setting. But when you shift to the mental health side, that becomes really complicated. Because every family is different, every parent's different, every child's different. And what do you do? Well, what we do in WeCare Journey is we refer, right? Because we are not the experts. So we do referrals, which is to professional, either psychologists or psychiatrists. And the other thing we do is make sure that someone's always on hand to listen, not with an answer, but someone who just understands, right? And be able to listen. Like, I can't help every dad in their life, and I'm not equipped to do so, but hopefully I can be just there to listen when something happens, right? And then Suki does it, and all the other families who try to coach for them to be able to do that as well. Just forming that network that if you need help, there's someone there to listen, to understand. We probably won't have the answer. We might know someone we can refer you to, but you know, it's someone to hopefully understand. Yeah.
Definitely.
And can I just add?
Sure, yes.
Yeah, so talking about resilience, I mean, this is something I'd observed as well in this study that I've learned. That's very true. I think for all our adversities, to even move forward or to take the next steps, we have to come to acceptance at different level of degree of acceptance. But you need to actually, you know, have the courage to want to move forward. And I think WeCare Journey, as what Suki, Edmund have been doing, this desire and willingness to actually help other parents, you know, who are going through the same journey, through telling and sharing their own story, is in a way provide a therapeutic effect, right? Shared grief, and when you see certain small successes, you rejoice in each other's successes, and that's actually increasing resilience. So that's very good, and that's actually on the basis of what, as the clinical geneticist, when we make a diagnosis of rare disorder, we usually have to find another family to support. And sometimes when we have seen families who have actually managed to cope through and are resilient enough, we would actually request permission for them to be a resource for other families, and usually they're more than happy to do that. Yeah.
Thank you for that.
I'll just quickly add, right? When Dr. Chung and the counselors sort of have that safe space, it's amazing, right? They're actually doing a study, but the parents and the patients all being there, being able to share, that was big for them. That's the first time many of them have ever shared with each other, or in public, or to a third person. And I think after that, it was just, a lot of them just shared with us, then personally said there's a lot of weight that was actually lifted. So it's just incredible sometimes, you think, just being able to share with someone
it's
that happened in the study.
right? It's a cathartic process to actually
cathartic.
To kind of release whatever that you go through. And very often what we've seen is that advocates, any kind of advocate, right? You could be advocating for, child abuse, or you could be advocating for a rare disorder. Very often you take in a lot of the negativity because you're kind of like a shock absorber. You're taking it in so that others might be strong. But that does not mean that we're not human, right? Every single one of us have had moments of weakness where we had to kind of just release out whatever it is that, that we've actually either heard or gone through. So thanks for that. And I think it's important. So those of you who are listening in and wondering who Sui is, because you've heard this name mentioned several times. She's the superhero lady that is also Edmund's other half. And she's also the co-founder of We Care Journey. So just because you hear the name, I wanted to make sure that she also gets credit for the work that she does. So thank you so much, Edmund and Dr. Cheng. Now over to you, Dr. Palmer. I wanted to ask you, we were talking about the importance of acceptance, the importance of shared grief, increasing resilience, family support. Now, on the other hand, families cannot support themselves, of course, first without the first responders that are there delivering the message to them or helping them understand. Patient navigation is extremely important. Now, in your view, how important do you think it is for doctors and researchers to really listen, right? I mean, not just listen, but authentically listen to their patients and the patient groups that they're planning to research for? Because very often we hear this, I understand how you feel. And I think all of us here know that that's the big boo-boo, right? Never say, I understand how you feel, because we probably only understand how we feel. What do you think, Dr. Palmer?
No, absolutely. And I think reflecting back when I started in research, I wanted to do interviews and focus group with families, and some of my colleagues, we can't burden those families. I heard that a lot. And we had a family day. So we had our first family day around genetic epilepsies just at our hospital. And we just asked people, we kind of put a board up and said, what's your wish list? What would you like us to do? What are the areas that you'd like to do? And people said they wanted to talk. They really wanted to talk, and they wanted to be listened. Okay. Yeah. And then that gave, I guess, us the courage to say, this is the first steps we're going to do. We're going to do interviews and focus groups. And I completely agree with everything that I've heard. And families have told me that actually being part of the focus groups was somewhat therapeutic. But then it's not just listening, it's listening and then taking it the next step forwards. And I think that's the thing. And it can get almost overwhelming. You're reading paper after paper. And as a doctor, I move into research when I feel I'm failing my patients and when I'm failing the families. And to hear time after time, for genetic epilepsies, the rate of chronic traumatic stress, what people were talking about, and for children with complex chronic conditions is so high. And many families don't move forward. Many families sink. Divorces are incredibly common, and the mental health aspects go beyond the parents to the siblings to the grandparents to the community, and we are failing rare disease families, and we need to change. We need to change that whole model of care. and go beyond the medical. Of course, the medical has to go forward. We have to get clinical trials. We have to get equity of access to the best possible treatments. But we also have to take seriously, very seriously, the mental health, the navigational support, the companionship support that we've talked about. And as doctors, we have to recognize our limitations, and we do not know everything. And if we pretend that we do, we're failing our families and the people that we see. But if we say, I don't know much about this, but I'm willing to learn, and I'm willing to be with you and to do everything that I can to try and help on this journey as a team, then I think that's a big step forward. But it's something we need to teach doctors to listen and to do. And that's something I'm trying to do with the medical students that I'm working with.
Thank you so much for that. Moving swiftly to Kris, we were talking about having a multi-stakeholder, multi-sectoral approach. Now, what if we were to look at it from a different dimension? Why do you think a localized approach to advocacy is important? I mean, it's important to connect to the regional group. It's important to also connect to the support systems that are available internationally, because, for example, in a lot of the Asia-Pac countries, some of the key research or studies might not necessarily be originating from institute in the countries that we are in, but instead in other countries or in neighboring regions that would be able to share this information. But having said that, there's always that understanding that while the science may originate from somewhere else, the approach to patient navigation and support might need a cultural nuance or an understanding of the local community that is present. So, Kris, in your experience, and I'm mashing your question together with the question that we're getting from Craig from the audience. Thank you so much for your question. So how important is a localized style of advocacy? And if we were to turn that on its head, what should a global rare disorders community look like then, if we've got hyper-local efforts as well as a regional and a global effort that comes together?
Yeah, thank you for the question. It's really interesting because when my son was diagnosed, he was 14 at that point. He had always had the condition but wasn't diagnosed till he was 14. And I linked up with an organisation in another country, and there were some stipulations around what I couldn't do with being part of that organisation. And funnily enough, the world leading research in SCN2A at that time was coming out of Melbourne, Australia. So not only was the basic science happening here in Melbourne, it was also the natural history study. The International Natural History Study is being run out of Australia. And how do we connect that, to your point, with the rest of the global community if we're not working together? There has to be an agreement to collaborate. We need to have a sense of the importance of people being able to be empowered to work in their local region. And there will be different nuances based on where people live. So I know, for example, in Australia, which doesn't necessarily have the cultural challenges, but we need to advocate our government to understand rare disease. And there's been some work in that, but not in my specific rare disease. If we don't do that locally, how do we get them to understand the impact on families, the changes to the health system that need to be made, the funding that needs to be made available, if we're not raising awareness around the impacts on families? And we're finding that a lot at the minute with genetic epilepsies, which are rare, but cause a lot more impact on families than other more common conditions. Our families are just not getting the supports that these other conditions are, and that local advocacy is a key part in our families getting the support that they need, but also access to potential treatments and care options. In terms of the international, I think we have to come at it as a team. I feel like at the minute, sometimes organisations are set up with a sense of ownership. We're the global organisation, but unless you have that collaboration and engagement with the regional groups, it can't be global, because you are not listening, to your point, Nadia, you're not listening to the voices of those in those regional areas to be able to adapt to those nuances. So I'd say collaboration, put the ego aside, come together and all work together. And this meeting is a great example of that, and I'm just really happy to be part of it.
I love how you've summarized it. Collaboration, ego aside, let's just get the job done, right? The reality of it is, I think that propriety feeling also comes from the fact that rare disorders advocates or even family members hold things really close to the chest. I mean, we're playing Russian roulette with life, right? And very often we've got our hearts on our sleeves. We've seen so many losses of loved ones, or at least the children and the families that we care for in our respective associations. So if I were to relate to some of the things that have happened for the Phelan-McDermott Syndrome Foundation, when we first started, they were just a family of 20, and that was really because Dr. Kathy Phelan and Helen McDermott were able to kind of group the first cohort of patients with 22q13 issues. That was really what it was before they even got a name. But since then, we've grown to become close to 2,000 patients across the country with multiple different languages. And to your point, Kris, it starts with something hyper-local. And while you grow to a regional and an international size, that hyper-local focus should not be gone. Because, for example, you've got everything from cultural barriers or language barriers, or how do we even reach the marginalized within the marginalized? So in this question, I want to take a question that was coming from Claire Stewart. I love your question. Thank you so much, Claire, for sharing. And if we were to play a devil's advocate here, very often we say that rare disorders are the ones that are sort of like a drop in the ocean, right? Just a few of us in between. But what happens to the few of us that are even more rare? So her question talks about the fact that the rare disease community is as diverse as the population of our countries. In Australia, I see that many of our rare disease organizations have low engagements with our Indigenous population and people from cultural and linguistically diverse communities. How do your organizations, or how do your advocacy organizations reach out to minority groups within the minority groups that you have in your own countries? And how can we learn from each other to ensure that the wave of rare disease improvements doesn't leave anyone behind? So who would like to take this question? Maybe I'll start with
Let
James.
me try.
Okay, we'll go James and then we'll go Edmund, because I want to hear the Australian perspective and I want to hear the East Asian perspective. Okay, over to you, James.
Well, I think the very basic thing is to look at your board and try and make it a multicultural board. We have a number of different backgrounds on our board. We've obviously got different genders, and we've included a person from that group that you've just mentioned. We haven't included them there just as a figurehead. They're all very active members of our board, but I think that's probably a starting point. Although I must say I'm not sure that we're reaching very well right into some of the original Australian communities. Some of the very remote communities are quite hard to get into, and that's ongoing work for us.
So in short, you're saying real meaningful representation and not just tokenism, and if possible, push them up to the leadership board where that voice can be amplified and heard. Correct, James?
Yes.
All right, but what happens if you are in a culture that's, I don't know, possibly even more of a melting pot, Edmund, when accessibility, technology, digital communication is also another problem? For example, if I'm thinking of Malaysia or some of the countries in East Asia, not everyone's on wireless, not everyone's on Wi-Fi, not everyone has a phone line. How would this work in a culture like ours?
It still starts with what James said. So even for our organization, it's fairly intentional that not only our board but our committee is extremely diverse. Mm-hmm. Diverse in their backgrounds, diverse in who they are, diverse in age, professional, all of that. Because that diversity is important, because that's the network that starts, right? We're not able to reach out and find everybody, and it's not the intent. You can't. But you got to be able to set up an infrastructure that gives you a pretty good chance that you can. And I think to add on to what James said is that you got to make sure that the barriers to reaching us is as simple as possible. So even simple things like, for example, membership, right? In Malaysia, most of the societies are built on a member basis, which is, you got to fill in this form, pay us a membership fee, and then we'll talk to you. No, we're not member-based, right? We're fully open door, and we're deliberate also from the start, because if you think about connecting, we got to make it as simple for someone to connect, literally a number or literally, a website, and be able, I think, after that, to shift whoever has contacted you to a person who's best able to build that relationship quickly. And I think the community and having a board that's diverse helps, right? Because not everyone's going to be able to connect with me as a dad, right? Because I would be having certain language skills and certain poor language skills in other areas. But how do you then match that best person to be able to make them feel at least I found some point that I can, speak to someone and find their way?
Definitely. And I like the fact that you're saying that, it's already tough enough for families or individuals with rare diseases or rare disorders, whichever you want to use. Breaking and reducing those barriers is key, right? To be able to ensure that they're able to find help or at least connect with someone who would be able to say, look, you're not alone. That's a huge start, to just say you're not alone. I like the fact that we started the conversation with how do we build this global network, and then we talked about the importance of having a multi-sectoral approach, having people from different backgrounds and gender, and then Kris also talked about the differences between local and regional efforts. Now I want to touch about the fact that very often when we talk about rare diseases, for the lack of a better word, it does sometimes become a little ageist. A lot of the advocates are actually parents or caregivers. Very often, if you've got conditions that hit the young and are rather degenerative or debilitative in nature, or our young ones are unable to speak for themselves, very rarely do we hear the voices of the young, the voices of those that have rare conditions themselves, or the voices of perhaps siblings and family members that are part of that circle of support. I wanted to ask a question to Dr. Palmer and Dr. Chung. In your research and in your view, what are some of the ways that we can help them better as well? Because I think while it's important to have caregiver voice, caregivers very often have a singular focus, which is to ensure the life or the quality of life of your loved one. But for the person with rare condition or the person with rare disorder, for example, someone with an adult with SMA, for example, they might be talking about sexual reproductive health or love or wanting to find a job with meaning. It's very different from, where you would approach things as a parent. If we could bubble wrap our kids with love and protect them forever and ever, we'll probably do that. So in your view, doctors, what are some of the things that we can do better for that?
You're absolutely right. If I could say, so I spent 7 years working for an organization which is around genetic counseling for people with intellectual disability. And yet there were no resources in Easy Read, for example, for me to try and help with actually getting across the messages and listening again in a meaningful way to the people that we were doing the testing on. And that to me was a really big problem. So we've actually just started a research program called Gene Equal, which is with experts at UNSW who've worked in education for people with intellectual disability. And we're conducting interviews, the first step, listen. So we're conducting accessible interviews with people with intellectual disability themselves about what their experiences have been with genetic counselling and where they feel there are gaps. And we're actually going to do a report, which is with the government, in our local government. And then the next step is to try and co-develop some easy read resources around genetic counselling and testing to really start that conversation that is a big gap that I think you identified.
Thank you for that. Dr. Chung?
Well, to engage siblings of probans or patients with problems is very important. I think in our report we did kind of uncover some of those, but we didn't actually have enough time to actually interview them separately to get a more thorough picture, and that was what our one of the recommendation actually to possibly highlight the siblings perspective in the research of persons with rare disorders. The other thing about the rare disorder being not all have treatment and because of a lot of them have life limiting. So we as clinicians, I feel what Emma was saying about failing this group of patients, and we have to feel in the need, because I myself take a keen interest in trying to learn and learn about pediatric palliative care in that sense to also advocate for these patients as well, those without treatment. Yeah.
Thank you so much. Kris, let's hear from you. I know you've got things to share as well.
Yeah, thank you. It's not so much related to my son, who is a young adult, but he does have a voice in his own care. But I just wanted to add, with one of the hats and one of the roles that I play, I actually work in consumer advocacy and engagement, and we've just got some funding to set up a youth engagement advisory group for this Health Research Alliance. So that's one of the ways that we're embedding that younger person's voice. And I just say that, again, to everyone's point, this is not tokenism. We are training these people. We are educating them. We are building up their capacity so that through this program, they will actually be able to come out the other end as strong, confident advocates. And I just think, let's not do the tokenism. Let's make sure that the work we do is empowering them to have that voice, because I think often there is a little bit of resistance just because of age, just empowering them, I think, is really important. And also, back to an earlier point that we made, this work has been done across all chronic illnesses for children and young adults. So it's not even in rare disease, but there's rare disease have a voice within that. So just, I guess, a reminder to think outside the box and who you're actually working with, and bring those teams together. And I think that's where we'll see the biggest shift.
I love that. Thank you so much. And it's important to understand that in different countries, the way policy and national action plans have worked may differ slightly. In some cases, we've seen in Asia Pacific, the move towards a very specified action towards rare disorders or the rights of people with rare disorders, including the rights and access to life and orphan drugs, is definitely more established in others, while others have gone down the route of trying to assimilate themselves together with the larger movement of rights to persons with disability. And I think it's an important thing to manage and to also understand. Earlier, Kris, you mentioned something that was really important: the voice of the individual, as well as avoiding tokenism and having them have a say in issues that are pertaining to their life. Now, what happens if that individual does not have the capacity to perhaps comprehend what is happening to them or be able to make those informed decisions to an extent? Because I also see in COVID-19, a lot of the tough decisions have had to be made by, of course, the parents. And some of the rare conditions that we know also include procedures or perhaps life-saving procedures that literally alter the path of the individual, includes, for example, sexual reproductive health or mobility or things like that. So, James, I wanted to ask you this question. What are your thoughts on this? You're on mute.
Thank you, Nadia. I just wanted to share an experience I had which relates to this question. Most of you would have heard of the United Nations Convention of the Rights of People with a Disability. Mm-hmm. I decided to go personally to Munich to talk to the United Nations, and the very first line that I used when I met some of the chairs there was, "I'm here to talk for people with Prader-Willi syndrome." And they said to me, "No, you're not." And I thought, what? What have I done wrong? My first opening sentence, and I've said something wrong. And so Stig Langvard, who was chair at the time, went on to explain to me that people with Prader-Willi syndrome can talk through me, but I can't talk for them. Now, of course, we're all well-meaning adults and we do lots of wonderful work for people that we care a lot about, but I needed to come home after that meeting and rethink how we can give them a voice. Mm. And to that effect, we did receive a grant from the government here in Australia to set up a 2-year program to an online community where people with Prader-Willi syndrome can start developing their own voice and becoming advocates for themselves. So that little encounter has made a big difference to the way we think, and it's actually changing a number of our programs.
Thank you so much. And I think that's an important piece. Now, moving on to ensuring that people have a voice. I'm going to be a little provocative here and ask perhaps Edmund to draw on some of the experience that I know WCJ have had to have. And James, you said something really important. We can talk through them, or at least be a representative of the words that they have shared to you, and this can be video form or whatever it is that you've done so brilliantly for the International Prader-Willi forum that you've had earlier with all the videos of the different PWS patients, and I thought that was really inspiring. But at the same time, in a more, I suppose, dark or a more sinister way, there have been instances, more than one, and I know we wish not to acknowledge it, but our individuals with RD are also more susceptible to violence and abuse. And you mentioned this earlier in your opening statement. For advocates like us, what are some of the telltale signs that we should be looking out for, especially for rare disorders patients that are unable to perhaps articulate what's going on to them, or at least those that you've seen and been able to assist? Could you share a little bit about what needs to be done better, not only in terms of hyperlocal approach, but on a larger approach in tackling the right to life and, of course, prevention of abuse?
A tough question.
Of course, because you're a tough advocate.
I'll try to tackle the local one first while I sort of try to think about how that can sort of, grow beyond it. But I think from a local point of view, what happens in terms of abuse, and we've got cases of that in our own community, right? And I'll be very careful about what I can and can't share and how I share. There has to be a safety line, right? Some sort of SOS available that people know that they can pick it up. Right, how that gets put out there, right? Is it a number? Is it an email? Do you share it privately? I think you got to just try all means. What's important is when someone's in trouble, they should be able to know there's a red phone that I can call, that I can get through to someone with something really troubling, right? Mm-hmm. It might be to a patient advocate group, it might be to a doctor, it might be to a counselor, it might be to, it doesn't matter. I think, at least from our point of view, as patient advocates, that's something that we can offer, because they could also call the police. They could, there are many other places that can seek help, but we could have like a safe line, right? A red safe line or red phone that people will know. But if you really need to talk to someone, you can either talk to someone you know, or you can talk to someone you don't know. So we've done that, yeah. But I think at the same time, you got to pick up some signs. It's not necessary that people will immediately tell you something's happening. I think it's on all of us sometimes to be just sensitive enough to sort of sense something's not right. Might not be us that ask the question. We might find within our own community who's best equipped, who's closer to that person to sort of find out something doesn't smell right, something's happening, right? And I guess if you think about it from a bigger sort of scheme, it maybe it's just something that needs to be there, right? Regardless of where you are, being able to understand that there's somehow, somewhere you can tap on, it could be anonymous first, that you can get a response back. And I think that's important too, getting a response back, because we've heard cases where people have called out for help. They didn't get a response back. And when you do it once, you do it twice, you feel hopeless.
Yes.
And you do sink. And we've seen that happen, right? They just sink and they say, well, it's just too hard, right? I call for help and no one comes. Yeah. So that response as well.
Thanks for that, Edmund. Kris, would you like to add on to this? Everybody's put on the spot.
Look, I think what Edmund suggested is absolutely the right way to go. We haven't experienced this in our community, so I haven't had first-hand experience, although if you're watching earlier, when Ursula talked about her own experience where she was actually accused of abusing her own child, which was so far from the truth. So I think we need to make sure that we're protective of all the people within that story before any judgments or assumptions are made. So I think it's a very tricky situation, but one that we need to be mindful of and be mindful of all the people within it.
I've had first-hand experience of being accused of abusing my own child. So living with a child with rare conditions, definitely not an easy thing to do. And sometimes explaining exactly what your child is going through and the different things that they're going through to perhaps strangers or well-meaning people who you meet at the restaurant or the mall or the car park isn't exactly the space where you want to talk in 30 minutes. This is what Phelan-McDermott syndrome is. Most of the time you're like, thank you very much. Thank you. I'm just going to bring my child out. Thank you so much for all of your sharing. I wish we can have another 45 minutes. Unfortunately, is what they say in Malaysia, masa mencemburui kita, which means time is envious of us. And unfortunately, that's all the time that we have today. Thank you so much for those that have shared your question. Craig, Anne, Claire, Daniel, thank you so much. I believe some of your questions have been answered. I know that Anne, as well as Daniel, or a question from Heather, was asking about how we can combine some of the efforts that we've done in our region, especially those that have got either headquarters or other organizations that are in Europe and in US, to be able to help some of the things that we're doing. And I think the answer for that is there is a lot of movement now, a lot of cross-country collaboration. And the people that you see here in this session are actually not only country leads, but also regional representatives of the many things that they're doing. So thank you so very much. I'm just going to end this with a quick wrap up of what is your one wish for rare disorders this year and beyond, if you can say it in one sentence. Let's start with Dr. Palmer.
That individuals with rare disease deserve and should have as high a quality, integrated, holistic care as any other person with a condition.
Wonderful. And Dr. Chung?
Well, I think we need to always think of hope, because, you know, with advent of all this collaboration, we can move forward, you know, more unitedly and in a more collaborated manner, and we can get a lot of things done. You know, that's the wish, but everybody would be unified. Yeah.
James?
I echo that sentiment, that is to work together to build stronger communities, because individually it's a long, hard battle, but together I think we can find more solutions and find a better life.
Wonderful. And Kris?
Mine's a little different. I'm certainly on the hope train, but I think also there needs to be a global approach to some of the higher decision making. So when we're talking about approval of treatments potentially in America, we need to consider what that looks like outside of the US. And yeah, we just need to think more globally when we're making decisions, and really bring in that global perspective, because the ruminations of some of those decisions make it harder for others in other regions.
Wonderful. And last but not least, Ed.
I'm going to add on to what Kris said, which is this global perspective. So there is a drive to get a UN resolution for rare diseases at the United Nations level. If you haven't heard of it, then please go to the Rare Disease International website. Yes. Do what you can to support it, because I think we need that sort of global perspective to provide the support that we need at a local, regional, individual level. So that's my wish.
Wonderful. So if I were to summarize everything that you've all said, we want a space where there is equality and equity, life with hope, a community that is united and stronger together, perspectives and action that are not only local and regional, but global in perspective. And let's all push for a United Nations Declaration on the Rights of Persons with Rare Disorders or Diseases. With that, thank you so much, everyone here. It's been goosebumps sharing the hour with you. Stay safe, stay blessed, and have a fantastic rest of the Global Genes Conference. Take care. Bye.